The Respiratory System, Chapter 20. Let's first look at the diagram of the respiratory system. Oftentimes when we think respiratory system, we think just lungs, but it really includes so much more than that. It includes our pharynx, which allows passage of air and food. It includes the larynx, which is responsible for speech. It includes the trachea, which is our windpipe, which brings oxygen into the lungs. It includes the bronchus, which you'll see are those big, like tree trunk passages into the lungs. And then it also includes the bronchioles, which are those tiny little fingers that shoot out from the big trunks of the bronchus. So we know that the respiratory system filters the air that we breathe. The trachea helps to bring oxygen into the lungs, and the alveoli remove carbon dioxide from the lungs. Alveoli are the little sacs. They look like kind of little deflated balloons that line the inside of the lungs, and they have capillaries on them. And so when we take a breath in, it helps to remove that carbon dioxide, and there's that exchange that happens at that point. Then we also know that the larynx produces sound associated with speech. Respirations. So inspiration is the process of breathing in. If you take a deep breath in, you inhale, okay, that's the active phase. You can feel the lungs expanding. Expiration is the passive phase. That's where we exhale. So one respiration is an inspiration, and an expiration equals one respiration. So if you know your normal vital signs or normal respirations for an adult, 12 to 20, and if you're counting and you get 40, okay, pretty sure you probably counted it wrong unless they are in distress. So knowing those normal ranges will certainly help you in the clinical setting. Changes in the respiratory system due to aging. We know that the lung strength decreases, the alveoli become less elastic and decrease in number. So this can have that carbon dioxide getting trapped into the lungs. The airways become stiff, the lung capacity decreases, and the chest muscles weaken. Other changes that are relevant as you age is that the cough reflex becomes less effective. So what could this mean for the elderly? If they aren't able to cough up that mucus and it stays down there deep in their lungs, that's an opportunity for infection to grow. And that's why they're more prone to pneumonia. The cough weakens, the oxygen in the blood decreases, and their voice also weakens. These are all normal changes in the respiratory system due to aging. So let's talk about some of the disorders of the respiratory system. First, there's chronic obstructive pulmonary disease, or also known as COPD. COPD is chronic, meaning it's long-lasting, and it's progressive, meaning it will get worse over time. Chronic bronchitis usually is brought on by smoking or secondhand smoke, pollution, things of that nature. It is an inflammation of lining of the bronchi, and it causes scarring and excessive mucus production. Emphysema is when the walls between the tiny air sacs in the lungs become overstretched. The air sacs weaken and the air gets trapped. Normal breathing becomes impaired. There is no cure for emphysema, and it's usually brought on by smoking or chronic bronchitis. Pollution can also cause issues with this in many people. With emphysema, there's an obstruction of the airway, especially during exhalation. So they feel like they're suffocating. Pneumonia is very common in the elderly, and this is an inflammation in the lung. It can be caused by viruses, bacteria, irritants. Remember we talked about if you're feeding them and they're coughing, maybe if the food or the drink goes down into the lungs rather into the stomach, this can cause aspiration pneumonia, and that's an irritant. The elderly are at a much higher risk for developing pneumonia because they have weakened immune systems, ineffective coughs, and they tend to be more immobile. And so when you're not moving around as much, you're not you're helping your lungs to expand and help clear that out. Some of the things that you should be watching for in your residents that may make you think pneumonia would be fever, chest pain with inhaling, coughing, shortness of breath, chills, or rapid pulse. If you see these things or these changes in your resident, I would definitely report it to the nurse. Sputum specimens, you want to check that out on that sputum specimen collection sheet. It's, I think, in the D2L, so make sure to look there. Sputum specimens are not coming from the throat. It is coming from deep in the lungs, okay? Your best time to get that is early morning. You don't want to rinse their mouth with any mouthwash or anything like that that would kill the bacteria, because they're wanting to see what is in their lungs. You're wanting them to maybe take some deep breaths and cough, which will help them really get that mucus up from down in the bronchus. Remember, oxygen is considered a drug and must be ordered by a physician. There are very specific guidelines for nursing assistants when caring for residents with oxygen. You cannot stop or start oxygen as a nursing assistant. You cannot adjust the flow rate. If there's any problems with the delivery device or the resident, it should be reported to the nurse immediately. Now, I know in the clinical setting, you are seeing things that are contrary to what the guidelines are for nursing assistants. You are seeing CNAs transferring oxygen from the compressor in the room to the portable tanks. That is not acceptable within the IDPH guidelines. It is out of your scope of practice. So be aware of what you see in the clinical setting is not exactly consistent with what IDPH says is your scope of practice. Be aware of what's in your scope of practice. There are different types of delivery devices for oxygen. The most common that you'll see is nasal cannula. It has a set of prongs. One goes into each nostril. It's most comfortable to use. They're able to speak and eat and drink with the nasal cannula on. Oftentimes they forget they even have it, so it makes it very popular device. The simple face mask fits over the mouth and the nose. It's great for higher concentrations of oxygen, but it's not as comfortable for the patient because it makes it harder for them to go about their daily life. It interferes with eating and talking. But this is really good for somebody who is a mouth breather. This is just an example of an oxygen delivery system that you might see in the resident's room. Incentive spirometer is very, very important to help expand the lungs after surgery or illness or injury. When a person is sick, oftentimes they don't want to take those deep breaths because it hurts. So the pneumonia very quickly and very easily can set in and cause the situation to be much worse for the patient or the resident. So this encourages them to cough and deep breathe. It helps to prevent pneumonia and atelectasis. And atelectasis is when the lungs become sticky and they stick together. It's kind of like they're collapsing from that sticky mucus in there. So we want to encourage, if we see somebody has an incentive spirometer, we want to encourage them to use